I'm looking to have a vasectomy done.
Oh, okay.
With sterilization, is there pain?
Severe testicular pain.
I'm not doing it anymore.
You don't want to get the snip. Okay, so if you cut that thing and you're going to go back now and do the deed,
Yeah.
what comes out? Have you ever had a condom break or burst or tear?
I've experienced the condom breaking.
Nhlanhla was using choice at the time. My name is Suhail
This is
Essa.
Dr. Nhlanhla Vilakazi.
Dr. Brendan Matthews,
Dr. Naseem Sharif.
And this is the
Gentlemen's
Gentleman's
Clinic
Clinic
Podcast.
Good evening and welcome to another episode of the Gentleman's Clinic Podcast. 6 South African male medical doctors on a mission to change the way in which we perceive men's healthcare. My name is Dr. Suhail Essa, and I'm joined in the studio with
Dr. Vishay Naidu.
Dr. Brendan Matthews.
Dr. Naseem Sharif.
And Dr. Nhlanhla Vilakazi.
And on today's episode, we are, as you can all see, not joined by anyone, so it's back to just the 5 of us that you know and love. So we're going to be starting off the way we always start off, and that's with interesting cases of the week. So, gentlemen, what interesting cases have you guys encountered this week? Vishen, I know you have something. I know you got something
Can I just
juicy.
mention something?
Yeah.
I got told this past week that Gentlemen's Clinic is gaslighting the country.
Gaslighting the country.
Yeah,
What does that
gaslighting
mean?
the country. So I don't understand this new word, gaslighting. I think it's a Gen
it's
Z
a- yeah, it's a
AMA
Gen Z.
2000 word. But apparently it's because we always say 6 medical doctors on the podcast, but we are 5.
Yes, because the sixth one is a ghost. He doesn't appear in front of the
Right.
camera.
So is he a financer?
We don't talk about
advisor.
that.
Blesser.
Yeah, he's a blesser.
Blesser.
He watches from afar and appreciates.
Yeah, but there are 6 of us. There's
There's
6 of us.
There's 6 of us, and we all add value to the podcast in our own unique way. And speaking of unique things that we encounter, Vish, tell us about what you had this week. We know you got something juicy for us.
Always.
So you work at Joburg Generate as well. I'm sure you know we get a lot of referrals from other
Yep.
hospitals. So essentially, there was this gentleman, pretty young guy. He was referred as a patient who, not sure who, but pretty much had a ring, a penile ring, basically that was stuck on his penis.
Yo.
So the issue with this now was it's been on there for quite a long time, and it had now eroded through quite a lot of the tissue, the penile tissue. So the urethra, which is the urine pipe, actually had been transected. It was completely cut.
Yo.
And the rest of the penis was now almost
Crowing around.
yeah, pretty much. So
Yo.
Wait, how long was this thing in place?
to be fair, I think the patient actually just gives a really poor history. So he also himself doesn't know. Yeah, so I mean, at the end of the day, you just have to treat the patient.
But
and,
you were saying earlier that when we were discussing the interesting cases before we jumped on here, that it wasn't just his penis.
so a strange thing actually I noticed, obviously when seeing the patient, he had these rings on his fingers as well. So almost on every finger, it was almost as if they were a few sizes too small, and they had now eroded through his fingers as well.
What?
Some of the rings, you could see that there's been long-standing effects where his fingers were pretty much almost down to the bone. Yeah, it was really
So
something
he
to
has
see.
some sort of like a weird fetish where he likes rings.
Or a mental health
It's a mental
condition.
health care
Yeah.
condition.
Oh, I've never heard of that. What problem does that fall under? Because clearly it's like some obsession. The man has an obsession with rings, specifically
No, so-
wearing rings too small on appendages that don't need them.
Can generalized like swelling of
So-
the body?
So I mean, it
from other
could be like psychotic disorder of some sort.
Yeah.
I think, you know.
I think it's more like he puts the ring on and is not the effect of pain that a normal person would probably experience.
True.
He doesn't experience that
True.
pain or that thought that I need to take this off,
100%.
because you said it basically squeezed through the penis, through the skin,
Yeah.
even
Something
transected
wrong.
through
Yeah.
the urethra. So
Yeah.
pee was coming through, like, not through the pee hole, through the shaft.
Yeah. So the urine was coming through the shaft.
Shame, man. Yeah, no, that's...
Well, did you manage to fix him up?
how do you fix that?
So there's a few problems that were wrong. So I think also, I mean, you kind of have to also get to the bottom of why this was happening.
Yeah.
So, treating patient holistically, with mental health care, illness, psychology, things like that. But essentially for that problem, the ring had to be removed, first of all. And then we had to get continuity of the urethra. Fortunately, the wound was actually quite clean. So we actually went under a reconstruction procedure for the urethra. And he's still actually, he's still recovering from that. So we'll see how that goes.
You said you guys don't do penile implants, eh?
I mean, as urologists, we do. But currently, where I work, we don't actually have... so essentially, the reps need to provide the penile implants.
Oh, so you don't have the
We don't
resources.
actually have the resources for that. I know in some other state sectors or state hospitals, they do actually perform them. It just depends on whether you can get the reps to bring the implants to your hospital.
Can I just ask something away from the rings now on the urologists? Is it true or is it just my experience that urologists are not offering vasectomies that much anymore?
In state?
Not in state, but in private. Because personally, I've actually inquired with 2 urologists, private urologists, and they say they don't do it. So I only have 2, but is it something?
So
that
it's
people are
not
doing?
something that's not within the scope of practice. It is. I think it's just there's a lot of litigation behind doing a vasectomy.
Yeah.
It's now becoming more and more, the litigation practice.
Why is it becoming more prevalent that you're getting litigation?
I'm looking to have a vasectomy done.
Oh, okay.
Okay.
I think I've,
You're done.
yeah, no.
You've had enough.
Vasectomy.
Huh?
What is a vasectomy?
So male sterilization. That's
Vish, you want to
basically-
tell us quickly about the procedure, just briefly, so that was
Okay, so for people, I think laymen that don't really wouldn't know the exact terminology for some of the anatomy, you have a cord on each testicle which carries your sperm. Okay, so that cord.
What's that cord called, Vish?
So that cord, which is called the vas deferens, essentially needs to be ligated or cut and tied off.
The same like a gynae would cut a woman's tubes that carry the egg.
Yes.
Well,
Someone like-
they don't really cut it. They
yeah,
just
yeah,
tie
yeah.
it.
I mean,
But yeah.
in simple
They
terms.
So-
cut it.
They do cut.
You cut and tie.
Yeah.
Oh, yeah. Oh, yeah.
There are
Sorry.
different techniques. So, I mean, with the gynae one,
Yeah.
the same with us is also different
Yeah.
techniques. But yeah, so essentially, depends how the urologist may do it. You can either have 1 or 2 incisions on either side of the scrotum. You need to
But you
obviously,
have to do both testes, obviously.
Yeah,
You can't just do one.
you can't just do one.
So what is the litigation
hope.
about? I mean, if I decide I want to be sterilized, I don't want children anymore, why would I go and sue a urologist now?
So, for example, say you now go there and you say, you want this procedure. They do it for you, and then a year or 2 years later, for example, you might find, if you happen to find another partner and you want to have children again now, or
Okay.
yeah, for example, it comes actually, it's quite often where someone may have now a new partner and they want to have kids with that partner.
Okay.
They obviously know what procedure they've done. They come back or they go to another urologist and say, look, I've had this procedure. I'm now with someone else. I want to have this procedure reversed. So technically, however, obviously it may be challenging to do the procedure. It's still, we're still able to technically do the procedure to reverse it and rejoin the tube. But the problem with that is there's a risk, obviously, of stricturing or narrowing of that tube. But secondly, if it's been after quite a while, what happens actually to the testicle is the production of semen, of sperm, actually isn't normal. It's not the same as it was before.
Yeah.
Okay.
Yeah.
So, because essentially once you tie that tube, there's a lot of back pressure in the testicle, which can cause damage.
Yeah.
So, although you might technically be able to realign the anatomy and the tube is now patent, the actual production of the sperm isn't. Yeah.
It's interesting that you mention that, because from discussions and stuff that I've had with other people who have undergone the procedure, they seem to believe, or have been told, and you can correct me, but they seem to have this idea that it's a fully reversible procedure, and hey, the moment you want to have kids again, we'll tie you back up and you'll get to go. But it doesn't seem like that's the reality here.
It's not. So again, saying
What would you say, like rates of regaining your fertility post vasectomy?
So again, surgically, the procedure is, you can do the procedure. Obviously, it takes long, it's technically challenging, and there are complications surgically, there can be. But depends. So for example, say you do the procedure now and a month later you want it reversed. At that point, the actual testicle, the factory that's producing the sperm, isn't damaged. So your rates are obviously much higher of being able to achieve fertility. Whereas, for example, someone who's now 2 years down the line, the rates are very low.
Yeah.
Yeah.
So just one question.
Sorry.
This vas deferens, does it have blood supply? You also cut off the blood supply?
No. So same like the fallopian tube. If you're tying that, it's just the you're just ligating the tube that's carrying the sperm. Because essentially, if you tie that off and cut it, there's no way for that sperm is not going to be able to go.
Yeah.
Yeah.
I see.
I think an important one is that obviously we encourage men to also equally get contraception, but with sterilization, is there pain? You spoke about back pressure.
Yeah.
Men experience pain.
So that's another side effect. So some patients may have new or severe testicular pain post the procedure.
Yeah, I'm not doing it anymore. No.
So it's not with everybody, but
you don't want to get the snip.
so it can be chronic ocalgia, which is chronic
And
testicular
then
pain.
another question, which I'm sure probably some of the viewers are thinking to
In
themselves.
really severe cases, they may have to remove the testicle
Wow.
Oh,
no,
wow.
No.
as a last resort.
It's fine. There are other methods of contraception. But the question that I wanted to ask was, and I'm sure a lot of viewers are probably wondering, like, okay, so if you cut that thing and you're going to go back now and do the deed,
Yeah.
what comes out?
Yeah.
What comes out during ejaculate?
So I think ultimately it is. I think it's a good option for sterilization if you've now committed to that decision or lifestyle choice.
Yeah.
But yeah, pretty much as you're saying, what comes out, it's
Just the seminal fluid.
Seminal fluid,
No
yeah.
sperm inside.
So just prostate fluid. Is it going to be
Yeah.
clear? That clear fluid?
yeah.
Not thick. I think
Well, there's no sperm in it.
there's no sperm, yeah.
Yeah.
Okay. So, I mean, at least, because I'm sure a lot of people are wondering, like, so then when you reach that climax, it's just hit and done. And there's nothing.
So-
that-
Yeah.
That would be
But-
anticlimax.
Something to also be like careful about is obviously after the procedure, it's not straight away that you can't now go and like ejaculate in someone and think they won't get pregnant because
Yeah.
there's still sperm in the
in the
tubes
actual-
that were already there.
So
Yeah.
what's the waiting period?
So most of the times, well, they say around 6 months, but ultimately what you can do is do a semen analysis to confirm rather than waiting a period.
Yeah.
So you do a semen analysis, it'll say obviously the sperm count and etc. on that, and then you pretty much will do it until there's no sperm in the ejaculant.
So every
that's the
to be safe,
safest,
to be safe, yeah.
every week or month you go to Lancet and pluck, and then they tell you no, there's no sperms. You're key.
Because essentially all you need is literally one sperm.
Yeah, that, Brendan. That's what people do.
Yeah. Okay.
But
just one last question,
yeah.
Fish. At what age would you say, is there even an age to do this procedure where you can say, according to your guys' guidelines, if a patient is less than 35, for example, they can't do it, or it's just, I mean, it's about what the person
so
prefers.
it's again what the patient prefers. So I've seen patients who are under 30 actually that requested the procedure.
Sure.
Yeah.
Okay.
Interesting. Well, let's move swiftly on to Brendan. We wanted to discuss your MEd, your master's study topic, seeing as the second part generally of our podcast is us discussing interesting case studies. And we thought, why not discuss one of our own doctors' studies that he's actually conducting. So tell us a little bit about your master's and the research that you've been doing personally.
Yeah, so over the past 3 years, I've been doing research at a university in South Africa. I can't say the name.
Okay.
But we've been doing research at a university. And basically, I've been looking at the concept of stealthing. You guys know what stealthing is?
No.
I've heard of it, but tell us.
Do you know what stealthing?
Yeah. So stealthing would be having protected sex or sex with a condom and removing a condom without your partner sort of consent or being aware.
Yes. So stealthing looks at a different type of condom misuse. So you get improper condom usage where either condom breaks, or you say you're going to use it with your partner and you don't use it, or it falls off, or you put Vaseline on and it breaks, or improper use.
Okay.
But stealthing specifically is the intent or purposeful removal of a condom by a penetrative partner without the consent of the receptive partner.
I see.
So I'm saying penetrative and receptive because it's men and women, that we looked at. So why it's so interesting is because in South Africa, we don't have data on this. And it's important because it has potential outcomes, bad outcomes. The specific outcomes that I looked at were unwanted pregnancies, STIs, including HIV, as well as psychological and legal outcomes. Because you could make a very strong argument that it's rape.
Of course.
So that's still being discussed,
What's your study methodology? How are you going to go about obtaining this data?
So I've obtained it already. I've got the raw data. So I'll share a bit about that. I can't explain too much until I have actually sifted the data and have all the pure data and publish. So I'm looking to publish by June this year. And then we can look at it again once I've published it. But basically what I've found is that it is happening. It is happening.
Quite prevalent in South Africa.
Yeah. So I've done a cross-sectional study, questionnaire-based, where I basically asked participants if this has ever happened to you and whether you've ever done it. You understand? So has someone ever done it to you? Or have you ever done it as a partner? And then all the potential outcomes, and we look at other potential variables as well. So what I can say right now is that what I see from the raw data is that yes, this is happening in South Africa, at least within that sample group. And yes, there are outcomes. So I think this is great because once I've published, it might influence a lot of research going forward. Our legal framework doesn't really speak to this type of behavior, stealthing specifically.
And also, I think it's an important topic about men and condom use. It's a big, for some reason, men don't want to use condoms. And then also, you hear the story that condom broke, right? So a man will be using a condom, he'll stealth, and he'll say, oh, it just broke. That's why I took it off.
Yes.
But you need to see those videos of how Durex adds. I've seen a condom stretch like massively. You can fill a balloon, right? Those condoms are resilient. They don't break, right?
For no reason. Yeah.
If it tears, the vagina wall will tear first before the condom tears.
What?
Honestly, that's how insane. There's no way you're breaking condom.
What?
So
You can put a condom on a cucumber, cut the cucumber through the condom.
So how do people always say this thing about condom tearing?
They stealthed. They took it off because they don't feel. That's the thing. That's the reason why.
Okay, look.
I think what is important,
put
guys-
the question to the table.
Yeah.
Has that ever happened to you? Have you ever had a condom break or burst or tear? Because I mean, Nas is suggesting that if you take a knife, you can cut a cucumber through the condom,
And the condom doesn't break.
and the condom doesn't break.
Yes.
Have you ever experienced?
I've experienced the condom breaking before.
I don't
And,
understand it. Yeah,
Yeah,
I've never.
I don't know. Maybe we're not using the
Same, yeah.
condom
Yeah,
brand.
maybe it's only
Nas is,
Durex that.
Yeah.
Nhlanhla was using choice at the time.
Explain
Banana flavor.
Explain that in front of the
I was protecting myself. I got let down by a condom. So,
Grape.
yeah, so I mean, that's not entirely, and I think we do see a lot of patients with that problem. It's very difficult to tell whether, I mean, someone is stealthing and someone,
But as Brendan said, it's the intent. It's the intent.
Yes,
And
yes, yes,
that I'm sure
yes,
with your study,
yes.
we'll be able to figure
However,
out.
like there are reasons that have been given why they stealth, right? So I hypothesize that they stealth or remove the condom without consent because they scared the girl will say no, or the receptive partner will say no. But the reason behind why, so just looking fast at the raw data, is there's a few reasons. Is that condom is dry, vagina is dry, they can't climax with the condom on. So they feel like, I'm not gonna, climax with this condom on. The only way I'm gonna climax is if I take the condom off. This is their thinking, and then they do it without getting consent from their partner.
Just ethically, like, how are you able to collect the data? So I don't know if we've chatted this, but yeah.
So the human resource or ethics committee at the specific university where I conducted the research, it's quite a robust process. They actually said to me that your research can cause potential harm. So I had to actually provide
How can it
services.
cause potential harm?
So there's quite a few ways in that people who might have experienced
Yeah.
it might relive it because
okay.
it might have affected them. They might have a baby through this or got HIV through it, and now they relive that trauma.
Just by your questioning.
Yes, and perhaps people who have done it might start feeling that they've committed a crime, that type of thing. So I had to actually provide services such as like counseling service, crisis services, suicide services, law services, and also legal services that are available after the study. Which
So is
people
this
could
looking
access.
at the person obviously who did it and the person who it got done to?
Yes.
Okay.
Yes, that's looking at both because you want to understand why someone does it, and also why what are potential outcomes of those that it's have been done to.
Okay, no, that's
Yeah.
very
So I'm
interesting. And I
looking
mean,
forward
one of the potential outcomes, as you mentioned, is transmission of STDs. So Nhlanhla actually had done some. Or do you want to add?
Yeah. So just want to know, obviously, in terms of just raw stats. I mean, obviously you probably don't have them as yet, but was it more common in heterosexual partners or homosexual partners?
So my sample size of homosexual was not high, was not large enough, but it occurred in both heterosexual and homosexual relationships. However, the frequency, I don't know yet, because if I had 5 homosexual couples where it happened versus 50 heterosexuals, I'll have to calculate a frequency because it could have been 10 out of 50 heterosexuals and 4 out of 5 homosexuals, and then it would be more homosexuals.
yeah.
So it happens in both. If you look at data in homosexual relationships, if you look at media, you would get the idea that it happens a lot there. There's some wild, crazy things that I've seen that happen among homosexual communities that I don't even want to get into right now. But
We can get into that.
Yeah, we can, but I think let's move swiftly on to the
yeah.
potential
Wait.
outcomes of stealthing, which is STDs. And Tlantla, you had come across quite a interesting study on the prevalence of curable STDs.
Sure. I thought it was very important for us to talk about this, considering that.
So one of the things we treat at the Gents Clinic.
Exactly.
Yeah,
but
STIs.
there actually was a media release or media briefing by the Department of Health to say that we actually have an STI pandemic in the country.
Wow.
Like a month ago.
Yeah,
if I'm
like
not mistaken.
January, February.
Jan. So I thought maybe, let's touch on this and yeah.
Of course.
I chose one study. There's a lot to read on STIs and everything. The reason why I chose this one is because it's a new study.
Okay.
It's a well-powered study. It was a randomized controlled trial. It was done in KZN in a very rural setting where we know HIV prevalence is very, very, very high.
in KZN, yes.
Yeah.
Highest, I think, almost in the world.
Yes.
In KZN specifically.
Yeah. So this study was conducted by, a couple of doctors, which I think is important we mention. Dr. Gerlamova and Chidua et al. Quite a lot of doctors, which is great. So they looked at any STIs, but primarily focused on 3, right? So they looked at gonorrhea, chlamydia, and trichomoniasis, right? So what they basically did is they took about 2,000 patients who were eligible for the study in that population, and I think there was something like 1,007. I just want to get the actual number. 1,743 patients who were actually eligible to participate in the study. And what they found in the result is that although the other or any other STIs were the most prevalent, the ones that they weren't really looking at. So what they did is they had to obviously collect blood and do the necessary tests in all these patients. Yeah. They found that gonorrhea was actually 5% of the patients that qualified. Chlamydia was almost 18%, 17.9% was chlamydia. Wow. Which we actually have been seeing, by the way, some of the patients that I've seen who've tested positive, even in Johannesburg, for chlamydia mainly, which I obviously before the study, I didn't understand why people were, singling out chlamydia. I just thought, it's one of them, yeah. But I guess also the type of medicine I practice, I'm in the eye. And then trichomoniasis was 6%. The other STIs accounted for 23.7%. 23.7%. And so basically the World Health Organization has been so in South Africa, how we currently treat STIs is we use a syndromic management plan. Basically, you kind of get the same drugs for whatever you have.
Yeah. So depending on just to for them to understand, based on a set of symptoms and an algorithm that we use.
Exactly.
If you've got a discharge with ulcer versus, depending on what your symptoms that you present with, we will treat a broad group of those symptoms with a set
sort of broad spectrum
therapy.
Antibiotics, yeah. And so basically what this study then revealed is what the World Health Organization has been advocating for, that yes, we understand that in our country, in a third world country where finances and all that is, that's why we even have these syndromic type of management, that we need to actually start thinking about shifting towards more community-specific etiology finding, like trying to actually find what certain communities or certain areas like this KZN district or rural area, what's prevalent there. So that when patients go to the local clinic, they actually get treated for specifically what they have and they get the best results. Because sometimes you might be covered, for example, if you treat them wrong. I think what they're trying to say is that certain infections or certain STIs can be prevalent in certain areas, and we shouldn't be sort of grouping everyone into this one sort of plan. And the best results are actually retrieved from making sure that you specify your treatment and target certain communities instead of a syndromic plan.
And I think that's kind of what we're trying to achieve with the Gents Clinic. We're targeting a specific niche, men, right? Men who have this issue and have the access to internet and can come conveniently and discreetly consult with us.
Yeah.
We've got a list of images that match kind of your symptoms. You'll select it on a survey, and based on that, it aids us in plugging that into the algorithm to get a diagnosis.
Exactly.
And so that we can give you the syndromic broad spectrum antimicrobial therapy that you require specifically for your problem.
Exactly.
So I think, very interesting.
And another thing that, just to add on what we obviously provide, is that even with seeing those pictures and seeing what the problem could be, I mean, since we are, one of the findings of this study was that the current way or the current methods in which we address or treat STIs is actually also not patient friendly. Like, I mean, imagine you have a chancre or an ulcer on your penis and you have to walk to a clinic, see a random sister you don't know, whip out your penis, you know.
Yeah.
But, you know,
Whip it out.
with the advantage of virtual
nobody's
medicine.
whooping that thing out when you've got an STI. You are revealing it at best.
Yes, yeah. But with the services that we're providing and the fact that obviously there's a lot of privacy that we've invested in our platform,
100%.
You can actually share these pictures, you know,
Yeah.
and it
In a
removes,
secure platform. You don't have to actually physically go and see
or
someone.
be ashamed.
100%,
I mean, it's way more different sending a picture than going and actually showing someone, you know.
Yeah.
There's no face to the picture. And it's nice because the doctor treats the problem and not you.
Exactly.
You know?
100%. That it's futuristic. That's what we're trying to achieve. But now, as we approach about halfway through our episode, one thing that we haven't done, and I thought it would be interesting to do, in this 7th episode that we have, is let's take some questions that we got from patients and see if we can give them proper advice based on the questions they ask. So these are some of the questions you guys have sent through either on our Instagram or YouTube or on our social media that you wanted us specifically to answer. So we decided on this episode, we're going to give it a shot. Are you guys ready?
Yeah.
Let's go. Okay, so the first question, someone asked straight up, why is my sperm thin and watery? Guys, any ideas? Naseem?
So it could be because there's a low sperm count. That is one of the reasons.
Okay.
Yeah. Or you could have just been ejaculating a lot.
It's also, he didn't specify whether it was throughout his whole life or something's just recently changed. So I think that's important to determine. If it was his whole life, maybe he's just got a really low sperm count. And that's why, as visual, when we were talking about the vasectomy and stuff, there's a difference between the actual fluid and the sticky stuff, the thick stuff, which is your actual sperm.
So you're just ejaculating seminal fluid.
Yeah.
So there's no sperms in that.
Okay.
Yeah.
Okay.
That happens if you, like you said, if you ejaculate too much. So like by how many rounds should you stop from a sperm point of view?
So when collecting a semen analysis, they generally say, so for example, if you go for semen analysis, they say you should at least be abstinent for at least 2 days.
Okay.
Okay. All right. So 2 days load.
So here's a question, and this one is not from patients, but if you with someone and you like these guys who say, I can go 4, 5, 6 rounds, is there a point where they now
the
know
tank is empty.
the tank is empty and they can now ejaculate inside and you won't fall pregnant?
But there's no sperm left.
There's no answer to be
Theoretically,
fair, but
like, so surely at a point there's
Not
no
that
more,
I'm not-
there's nothing left
Remember
in
that
the
you
tank.
need one
You only
sperm.
need one
You only
sperm.
need one sperm. That's what you should
Yeah.
say. You only need one sperm.
So that's not at all a method of contraception.
Yes, not
now.
at all.
Not at all.
Disclaimer, please.
Yeah. Okay.
Yeah, but also the other thing, interestingly, is, and it's something to probably consider. A lot of patients, like when they talk in their lay terms, they'll say, "No, I'm leaking sperm." They'll say my sperm is like thin and watery and leaking sperm, and that's actually a sign of potential discharge, actual
STD.
urethral discharge from an STD. So it could also just be that you have an
And we've heard
STD.
that a lot. All of us have heard that, eh?
Yeah.
And they-
That was
Patients say
when we were in med school still.
The bra says, I'm leaking sperms. Sperms are coming out.
Meanwhile, it wasn't that. It was
Yeah.
an STI. So, but the other thing that you're also mentioning, Naseem, is with regards to frequency. So, increased frequency of ejaculation potentially can cause you to have a more thin and watery.
Yep.
Yeah. Anything else, or shall we move on to the next
We can
question?
move on to the next one. I think.
Cool, perfect. The next question someone asked is, I had sex with someone that I don't trust. Can I get HIV from it's a two-part question. So I had sex with someone that I don't trust. Can I get HIV from oral sex? And how long do I have to take that ARV medication? Is there also something that I can use, a medication I can use to prevent from contracting HIV? So let's first answer the first part of that question. So they had sex with somebody that they don't trust. Now they're also scared, firstly, about specifically oral penetration. Can you get HIV from oral penetration? My answer is yes, potentially.
Yeah.
I don't really want to speak about the medical, what medically we know, because South Africa has such a high HIV rate and prevalence
Yeah.
that I feel like if you talk about what we know in the medical world, people might use this in the wrong way.
Yeah. So if you
However,
start talking about, in the saliva, there's not as much.
yes, and if you say like, if you have sex, there's actually like a less than 1% chance of getting HIV from vaginal penetration. If you have anal penetration, then it goes to like higher 1.5 to 2. I stand corrected of this, but it's there in that range, I know for sure. So I don't want people to think, let me go sonoro, because it's only 1%. No,
Oh my goodness.
I understand. These prevalences, these rates change with your exposure. How long you are in there? Are there
Yes.
cuts on your penis? Are there cuts in the vagina?
Of course.
Are you
You know,
circumcised?
are you circumcised?
Viral load.
The viral load of
yeah.
the patient, are they on medication? So we need to be aware of this. But generally speaking, those are the percentage chances. However, another thing that's very important is that all our guidelines say, if you live in South Africa and you are exposed to HIV in South Africa, you are positive until proven otherwise. That's because we have the highest number in the world.
And that leads us to the question that they were asking about, there's a medication. They've heard of a medication that you
Yeah.
can take after you've had unprotected intercourse with someone that you don't
Yes.
trust. Or I wouldn't even say just anyone.
Let's first
Anyone.
classify-
Then.
Let's first classify those different kinds, because there's PEP, PEP, and then there's PrEP,
Yeah.
PrEP.
So define that for us. Yeah.
So that's first one is, let's say PrEP, right? Pre-exposure prophylaxis. So
Which they
pre-exposure,
also asked about. Yeah.
right? So pre-exposure prophylaxis is the medication you take before you have sex or before you have an encounter to prevent HIV, right? Obviously, guys, there's a lot of people on PrEP. Actually, there's a lot of people motivated to go and spread PrEP in the country, right? PrEP does not prevent STIs. PrEP does not prevent pregnancy. So if you are taking PrEP, you must know that you must still use a condom. This is an important point, right? So, okay, let's say on PrEP, you take a tablet every day, right?
Yeah.
And this prevents HIV. right?
Lifelong, huh?
Basically.
Yeah.
Once you stop, I think you can stop for like your last encounter, you can have it after a week, right? So from your last encounter, 1 week afterwards, then you can stop. Right? So that's PrEP.
How long before?
2 days or
It used to be 7 days for anal, and they divided anal, penis, vagina, but I think now all across the board, I think it's like 3 days, 2-3 days. Yeah.
Then there's PEP, right? So PEP is post-exposure prophylaxis. So after you've had something that was not planned, an encounter, right? So now you want to prevent HIV, maybe some stealth thing, or you got a needle stick injury or something that happened. So you'd take an antiviral medication for a month afterwards, right? And then you must test again after 6 months.
Yeah, and it's important also. I think they were asking the question about how long after. So ideally is sooner rather than later. But I think the maximum amount of time is 5 days post unanticipated intercourse with someone that you.
So the
not
best
familiar
effect
with.
is 3 days. The best
Your best
effect,
effect,
72
yeah.
hours,
Yeah,
and
that's
that's what we tell everyone. But high risk exposures, they do define sort of like 4 or 5 days, but that also shouldn't be abused,
Especially in South Africa. And
especially in South Africa. Yeah.
Yeah. So, I mean, look, if you find yourself having had an encounter, you can always come to the Gents Clinic. And it's, again, it's another means for accessible healthcare to people. It's embarrassing. I've had it. I've seen it myself with patients coming in the middle of the night to the emergency
what do you
department.
mean you've had it?
No, I mean, I've had the experience of with a patient.
Oh, okay.
Not myself.
It's not necessarily just sexual exposure. It's, us operating can be needle stick injuries and like eye splashes as well.
Exactly.
Yeah, I mean, you've taken a PEP for eye splash and stuff like that.
Have you guys heard of on-demand PrEP?
So yes, I've heard of that. So when a patient is now, they're going for a holiday where they think they may be engaging in risky sexual behavior, they're like, all right, I need to come and take that.
But so the research was done on men who have sex with men and transgender women.
Okay.
And it found that, and also we describe it in people who are sort of like in abusive relationships. So let's make an example of a man who works, let's say he's abusive and he works away from home and the wife knows that he's coming home this weekend. And then you go to the clinic and you be like, listen, my husband is coming back. I suspect he's HIV positive. He's abusive to me. I know he's going to want to sleep with me this weekend and he never uses a condom. I want something to protect me. He's coming tomorrow. It's also for prostitutes. And like I said, men have sex with men, for example.
Yeah, so any risky sexual
So
behavior.
basically, it's called the 2-1-1 principle, right, Ness? So if you know you're going to have sex tomorrow and it's going to be high risk sex, like we explained, someone who's probably has HIV, you take 2 tablets today, and then if sex doesn't happen, then you don't take any more. But if sex happens, then you take 2 today, 1 tablet on the day sex happens, and another tablet the following day.
Yeah. And that's enough? Is
Yeah,
that sufficient?
and that's been shown to be effective to protect from. But of
Interesting.
course, if sex is now going to continue on the Monday, Tuesday after the week, obviously now
you must continue the tablet
Yeah.
every single day. Yeah.
It's interesting.
No, I mean, look, and that's why we have the platform where you can sit at home. If this has happened, you don't need to go. It's uncomfortable, again, going to a nurse, telling them, I've had this, the condom burst, These are the types of conversations you have to have with someone at midnight on a Friday night when people are being stabbed in the background. So
And I think
ideally, it's
yeah.
an easier way for you to consult with a doctor, and we'll give you advice, and we'll obviously try and counsel you on safe sexual practices
What I
and
think
give you the
is-
medication that you require.
Also good for our patients is that many times I've had patients consult us at the Gents Clinic and maybe they're a bit embarrassed or insecure about their complaint and they don't want the video on. So I'll just say to them, okay, put your video on so I can see I'm talking to a person, let's have the introduction with your video on, build a rapport, I'm Dr. Matthews, I'm so-and-so, I'm calling from this place. And then once we've set that in, then they switch the video off and they're comfortable to talk, from that.
100%. Let's move on to the next question. This patient wanted to find, or this follower of ours wanted to find out if have you checked your test levels, and how can I tell whether I've got low testosterone? Are there like specific symptoms or things I can look at on my body that will alert me to the fact that I've got low testosterone without actually having to go for the test first? So I think let's first talk about the clinical signs, Vish. What are the actual clinical signs of low testosterone?
So I think we can all just chip in with some answers, but
But we haven't
as far
heard
as
from you in the last-
I can know it's so decreased muscle mass.
specifically, I think you were mentioning.
I think specifically they say in your quadricep, so they look at quadricep. Yeah,
I think that might be me, yeah?
I suppose excess body fat percentage, especially abdominal, and then there's quite a lot of other things.
Yeah.
I think also
Yeah.
like beard growth and hair loss is also a thing, because a lot of that hair loss, a lot of that testosterone converts to DHT. So if you have high testosterone, you could be having a big beard and hair loss as well. That's one
Some
of the
guys
signs.
actually think that they like alpha males when they have a long beard and
and
baldness. Actually,
No, but that's you're saying because they probably just have very high levels of DHT. But DHT is very potent. DHT is the very
So
potent
it's
form of
saying they can have
It's a
testosterone.
sign
low
of
testosterone.
No, if you're balding and have a big beard, it's a sign of high testosterone.
Oh, hi.
yeah, that's what
Okay,
he's
so they
saying,
are
yeah.
alpha males then.
Yes, those
Yes.
guys are the alphas.
Why does it look like those guys are mostly Muslims?
Yeah.
No, I think it's
So,
a good point.
you can just see.
No, it's because
You can just see someone by if they have a beard or if they're going bald. You can make an idea of what
Yeah.
their
Their test
DHT
levels.
versus testosterone,
So that's
levels,
why-
their muscle mass.
I
their,
honestly think there's a lot of genetics to it as well.
That's why
There's a huge, there's a huge amount of genetics.
yeah.
There's
Because there's
also-
certain
yeah,
groups
it's
who don't have
they
that,
have
and there's
high
certain groups
test,
who
yeah.
have that only,
Yeah.
like who have a lot of hair
Gents.
and huge beards.
okay, but
And certain groups who have
okay, but you can
as
tell.
you-
little
as
hair,
you were
very
saying
little
that,
beard.
You can tell at makeup. You see someone with a lot of big muscles, no beard, and they're growing bald. There's something that you can tell from that.
they're choosing.
They're juicing,
Ah.
right? Yeah.
Yeah, I mean, you look at the biggest bodybuilders in the world, like
I
the,
don't think
the
so.
guys in the
that
IFBB
doesn't
Pro.
make sense.
It really
because-
doesn't.
No, that's not.
It doesn't make sense. Wait.
doesn't.
Okay, why? Why not?
So, for example, if you're taking anabolic stuff, you're going to grow a lot of facial hair as well. You can be bald and you have a lot of muscles, right?
And you have a
can't-
beard.
And you have a beard.
Because, I mean, you're
I
giving
think he's,
yourself either
he's
test.
generalizing too much.
Oh,
Yeah,
yes,
it's
yes.
the
No,
generalization,
but
but-
the thing is that it's important to correct this because now we don't want everyone who's bald. And I mean, we're talking of a country where majority of the population is black and bald. And balding is
But they don't have beards.
yes. And I mean,
Yeah.
if you watch, like
It's genetic, yeah.
it's genetic,
It's genetic.
and it's a lot. Like I mean, I look at my uncle, and look at my dad, for example. You know. I really don't think it's. Whereas if you look at your brothers, your uncle, is there anyone in your family who doesn't have a big beard? No.
Yeah, true.
Is there anyone with, you know?
So it's
you
definitely
understand?
a big genetic
There's a
component to
huge
it. But if you look at
genetics
the
to it, so-
IFBB Pro champions, if you look at that stage, all those guys are just bald.
Yeah, yeah.
Yeah.
Okay, but no beard.
So this thing of
but
Muslims,
bald.
it's sort of making sense now why in Islam you can have multiple wives. I think Prophet was onto something. He just knew these bras are going to have high test. They need more wives.
Bald and bearded.
Yeah.
But
So the
let's-
other
let's-
aspect to that question was,
Yeah, have we checked our tests?
Yeah.
Do you want to go around the table?
You guys are Muslim, so you're going to tell us now.
Yes, yes, yes. I think, yeah, this clown, yeah.
Now let's end with me. Everybody else want to tell
Okay.
this, and then I'll tell
Yes,
you my
what is
story. Because mine is more.
So what's the
research.
normal range for us? We're about 30 to 32 years old.
We'll have to check it.
So I think
But
probably
roughly.
I think we should
Yes,
be.
we don't have time for you to
In
check
units.
this. Just
Come
give
on,
us
man.
give us the.
We should
thing.
be at least
Look,
350.
the
Like,
range
be
that we
accurate.
use at our clinic is 300 to 660, right?
Yeah.
So that's it's
What-
obviously
What measurement is this?
is it nanomoles per million?
Nanograms per deciliter.
Nanograms
Yeah.
per deciliter, yeah. But
Okay.
for the layman who doesn't really
So
care
none of
about
us
that,
should be below 300 or 350.
yeah,
basically.
yeah. So that's
Wait, the thing is that there's a range of
Unpowerful.
testosterone, right? But it needs to be age
Age-specific.
age
That's
specific.
what I'm saying for 30-year-olds.
That's why I want to go just check
we
the.
30 to 32, but
Yeah.
we shouldn't be below 350.
There are other things that need to be also looked at. So your free testosterone, your sex hormone binding globulin as well. So it's not
very
just.
important,
It's
yeah,
just
it's
not. Yeah.
Okay.
That's
it's,
true.
it's
That's
not
also-
to be looked in isolation, and that's
Yeah.
why you need to come and actually consult. But
And
if you're looking-
and the blood test needs to be taken at a specific point in the day.
Yeah.
preferably before 10 a.m.
So-
Average is 420. By
So
the way,
we've
for
done
our age
all
group.
hours, and we
I
should be at
actually haven't.
420.
Yeah.
You haven't.
You haven't done
tested,
yours?
Yeah.
Naseem, have you done yours?
What was yours?
Last time you checked?
600.
Oh, wow, okay.
Yeah.
Have you done yours?
It's powerful. Mine was 680.
Sure.
Yes, I am key.
And I'm
Tanda-
470, man.
470.
I think NASA's theory is correct. eh?
What genetics do I have now that's making
Yeah.
me at 680?
I don't
Is
know
this,
what genetics you have.
Is this
man.
on or off?
Huh?
Is this on or off?
On or off what? I'm not on TRT.
No, not on DRT. Like
Oh, no, what are you on?
Nothing. I don't know what he's talking about.
Okay.
What are you saying?
Ashwagandha.
Oh, I'm on ashwagandha. I'm 700.
and Tungatali.
Tungatali.
Zinc and magnesium.
Yeah.
Now, my levels, I checked it earlier this year because I was a little bit, I just wanted to screen. And then earlier this year, my levels were around 440. But then subsequently, a couple of weeks went by, started experiencing a lot of the symptoms that you find on the Adams questionnaire.
What are the symptoms, eh?
So the symptoms, firstly, the Adams questionnaire is just one of the surveys we use on our website to determine whether you potentially may have low testosterone or the clinical features. And so the things I was actually experiencing is like very low energy, sleep disturbance, like not able to sleep well at night. And then subsequently then in the day, I'm feeling tired and exhausted. And then I thought, is it the sleep that's affecting me in my work and I in exercise? Because I started to not be able to perform as well in the gym as much as my libido started to decrease. I didn't have as much sex drive. And then also mentally, I was just having like brain fog, you know, where things that I'd be able to process much quicker was now taking me way, way longer. And then I started thinking to myself, okay, you know, I'm quite a high risk on this Adams score, which I tell patients all the time, you know, you need to get help for this. So I said, okay, I'm going to go to the lab. I'm going to get my bloods checked. Let me check it out. So recently I checked my levels and they were just under 300. So about 280.
And this your free total?
Yeah, this is the free testosterone. All the other parameters were normal, except my luteinizing hormones were slightly on the higher limit of normal. I don't know if we want to discuss that fully, but in the interest of time, maybe we can delve much deeper. And I think we have had one of our previous episodes. We discussed all the different tests. We'll just put the link somewhere here so you can watch that specific episode where we talk about the breakdown. But basically, with having the low testosterone or slightly lowered level of testosterone with the symptoms, so not just in isolation, I definitely feel like I'm a candidate for TRT and I'm experiencing all these symptoms. So why not at least give it a try? Although my concern is, and one of the things that people must know is if you start pure TRT, testosterone replacement therapy, you are at risk for infertility. And I ideally would want to have kids in the future. So we're here. Let's chat about what are my options. And I think we as a team, you know, we oftentimes discuss patients' issues, problems. And so I put my case forward to everyone to give me advice specifically on how best to treat my current situation. Yeah.
So just in terms of general measures, I would first want to look at sort of lifestyle changes. So you did mention the fact that you do exercise. So looking at the type of exercise you do. So we all know that, you know, there's certain exercises that would naturally sort of increase your amount of total testosterone, meaning free or bound. So things like squats and high intensity, deadlifts. So obviously trying to incorporate that. That will be just the general, right? Trying to look at your diet, trying to make sure that you're obviously on sort of low fat diet, or on some kind of a diet or sort of a diet plan, right? And then I would instantly consider supplements. But what I've noticed with most of the patients that we see, they've actually already read up on that. You're a doctor. I'm sure you've already read up on most of that. You're probably already on.
And the frightening thing for me was like, I could see that I'm not making any progress in the gym and I'm not seeing the same results that I would get if I had to do these exercises, say 2-3 years ago. I wouldn't have the same feeling. Like, I can't even explain it to you. Like, the same energy level that I had to do the exercise, the same like motivation and drive, which is something that is led by testosterone.
I want to make a point on diet, right? So testosterone is a cholesterol. You need cholesterol in your diet. So I know you only like white eggs.
No. I've been eating, and we had this conversation, and I eat whole eggs. I don't cut out the yolks. I make sure I get enough. I'll eat like 3 to 4 eggs every morning.
For me, what I've noticed with you is your sleeping pattern. You work shifts, so you'd work 3 days night, and then 3 days off. Is that so?
So currently, not anymore. But at a period there was, and definitely that could have been something that affected it.
Definitely.
Your sleep is very important.
So let's say, we've done that. So we've done the diet, the exercise, the lifestyle, the supplements as well. Supplements are important because, I take supplements. I'm sure we all take supplements daily.
I've been taking the ZMA, the Tongat Ali, the ashwagandha as Naseem recommended. And and then still
Yeah,
I'm experiencing
yeah.
these.
And then
Vitamin D as well.
So
Yeah,
using
D-
using TRT,
D3?
Vitamin D as well. Yeah.
Yeah.
using TRT and maintaining fertility, is there a way that we can?
well,
So if you're using human chorionic gonadotropin hormone, there is room for in replacement of using testosterone replacement therapy. You can use that
actual
as an
testosterone.
alternative.
Yeah, I think
HCG,
just to explain to
Yeah. And have you guys heard anything about using? So let's say Suel does consider TRT, right? Or let's say Suel was on TRT, but he's coming to see us now for fertility issues. So he wants to get his fertility back. He's telling us that, you know what, doc, when I started, I was on 200. I've been sitting on 500. I mean, I'm the best form, you know? Is there room for HCG for someone who's not who doesn't have secondary hypogonadism? Like, because essentially what HCG does is that you're increasing LH, FSH, you're stimulating your testicles to start working.
Yeah.
Can they start working if
You
you
mean
already have
For someone
exogenous?
for someone who has secondary hypogonadism, so you meaning there's a problem at the
on top
in
or
the
Yes,
brain.
no.
at the bottom.
No, I'm saying someone who doesn't have it.
So it's primary hypogonadism.
No. Listen.
Primary is
So-
a problem at the testicle.
Yes,
Secondary
yes.
is at the,
What I'm saying is that the person doesn't have problems. He's on TRT.
He just for purely
Yes. So when
to
you're on
increase.
TRT, we're forgetting down there, right?
Okay.
Yes, which is why you get infertility or shut down, right?
Yeah, shut down.
So I'm saying you're
taking
kickstarting now
Yeah.
by giving them HCG,
yeah.
hoping that their testes will start working,
Yeah.
just making like normal, natural, and then they're still using the sort of the test that they're injecting
Oh, so
Yeah.
to use it concurrently.
concurrently. So my question was, is there room for that?
To
And
kickstart-
do you guys know?
Start the
And to
factory
use the
again.
TRT
Yeah.
at the same time.
Yeah.
I actually
For
haven't-
patient-
Yeah.
So I actually yesterday, because we actually had this discussion yesterday on our WhatsApp group, and so I decided, because in Atlanta you had suggested it, I said let me go do some research on it. Found a couple of studies. Some studies say that it's not really advisable to do both simultaneously. Some say it's fine, it's completely safe. Essentially, what you're doing is you're stimulating the factory. You're stimulating the brain to tell the factory at the bottom, hey, you need to kickstart and increase the production. If you're gonna, on top of that, give yourself testosterone, the risk is that you may have excessively high levels,
Okay.
and then all the side effects that come with that, the gynecomastia, etc. So they advise, preferably, if you're trying to preserve fertility, in someone like me who's never used anabolic steroids or anything like that, rather try and just use HCG to kickstart your HPA axis and get your hypothalamus, your pituitary, to tell your testes, make more testosterone, see what your level is. If you're still not getting the right level, you can still maintain the beta HCG and give testosterone to optimize your testosterone level and still to preserve the fertility, because essentially what it is doing is it's giving you the LH and FSH surge that you require.
Yeah.
And interestingly, also in that same study, with just HCG alone in an 8-week period, they found with patients who had hypogonadotrophic hypogonadism, so
Low LH and
low LH and FSH. So patients that basically throughout their lives have never, idiopathic hypogonadotrophic hypogonadism. They specifically did the study on them with HCG, and they found not only did it increase testosterone, libido, and fertility, but also penile length by an average of 1.7 centimeters. So I'm starting my journey.
We established on the last podcast that we fine, man.
Yeah.
Whether you at
Yes.
10,
Speak for yourself.
In terms of
Listen.
size. In terms of size, it's important. It's important.
Yeah. So I think that that's an option for me. I think that that's something I would definitely like to consider. The other options is clomiphene citrate, Clomid, which also basically tells your brain to tell your factory at the bottom, you need to produce more testosterone, but also preserve the fertility.
yeah.
Which is essentially what I ideally would want.
Yeah.
So I'm keen to at least try and see if I do feel better. I want to feel like I did a few years ago when going to the gym wasn't a difficult thing. And like just performing, at work didn't become a difficult task,
Yeah.
That's just something that I am looking forward to with being on this specific tailored TRT plan. Yeah.
Good man.
Yeah. Any other things you'd like to add on that before we close?
Guys, if you want to do your Adam score questionnaire, go on the website. There's a free questionnaire to do.
Yeah,
To try it out. See if you have
gentsclinic.co.za.
it.
You can come and you can actually answer all the questions. It's a completely free survey. It gives you a response. It gives you feedback based on the questions that you answer, what you may specifically be suffering with. And then you can come and chat to us about your TRT journey. Start your TRT journey with us. Talk to us about fertility.
Yeah.
Talk to us about whether that's an issue for you or not. I mean, if it's not, we can give you straight up testosterone, and we have options. There are options, the different treatment modalities. We have testosterone trochets. We have testosterone cypionate injections. There's a wide variety, but I think that the first step is actually just taking the leap and saying, I may have the symptoms. It was tough for me to even admit it to myself, but I said, hey, I may be a patient myself, and relinquish yourself to that. As we know, men don't like to seek help, and they maybe seek help too late. So come early. Let's catch it early when you're younger. Let's try and fix and rectify the problem and get you healthier for the rest of your life. That's what I think.
Yeah. Cool. Any other questions?
Look, I think we kind of are running out of time.
I see quite a bit of questions there, but maybe we'll address them.
We'll address them in our next episode. We would like to touch a little more on weight loss. That's something that we are trying to work with in tandem with TRT, because we do know that patients that are diabetic, obese, or have other lifestyle diseases like hypertension and cholesterol, it can affect their testosterone, and so we ideally want to incorporate TRT with a weight loss program that our patients can benefit from.
Yeah.
So
important.
I think we'll discuss that more in depth on our next podcast episode. We look forward to having more guests and more great chats.
And more questions.
Yeah, so that's another episode of the Gents Clinic. Thank you guys for watching. Please like, follow, subscribe, watch all of our videos, and don't forget to visit www.gentsclinic.co.za. Book a consultation, have a chat. We're always available to talk, and we're always willing to help. My name is Dr. Soya Essa, signing out.
Yes, guys. It's Dr. Brendan Matthews signing out.
Dr. Atlanta Bilagazi signing out.
Dr. Nassim Sharif.
Dr. Naidu signing out.
All right, that's been another episode from us. Take care, peace, love, good night.